So now let's talk about our chronic lymphocytic leukemia and small lymphocytic lymphoma. So why we put this together? They're the same cell. So we see the cell that's characteristic for this in the lymph node, you call it SLL. If you see it in the peripheral smear, you call it CLL. It's the same cell. Okay, so again, that's why they put some of these neoplasms together. Okay, but you can get some lymph node involvement with CLL, so be aware of that. Now, why is it called small lymphocytic lymphoma or chronic lymphocytic leukemia? Because you're going to see a whole bunch of small looking lymphocytes. They're going to be B cells, so your B cell markers will be positive. However, look for the CD5, which is a T cell marker, also be positive with these cells. Now, with our CLL, 1920 will be positive along with CD5, so be aware of that. Okay, they're also going to be CD23 positive. So most of them are going to be of B cell lineage. A small percentage can be of T cell lineage, but usually on the exam, they're going to give you the B cell type. Okay? Now, very important that microscopically, if it's going to be a small lymphocytic lymphoma, what you're going to see is diffuse involvement of the lymph node with these small lymphocytes. So you're not going to see the sinusoids or the follicles. So that's your so-called effacement of the lymph node architecture. So to make a diagnosis of lymphoma microscopically, you got to have effacement or disruption of the normal architecture. So it's called small lymphocytic lymphoma because you see a whole bunch of small lymphocytes. Okay. However, with CLL, in the peripheral smear, we're going to see many small, normal appearing lymphocytes. Okay. However, other thing you're going to see, these so-called smudge cells. What are they? What happens is when you actually do the peripheral smear, you put the blood on one slide and slide the other slide across it to make the smear. The neoplastic cells are fragile and they smudge. So you don't have smudge cells flow around your body with CLL. You actually see them when you do the peripheral smear. Okay. Sometimes you see the term parachute cell in relationship to the smudge cell. Okay. And of course, your bone marrow biopsy will also show numerous normal appearing neoplastic lymphocytes. Now, you see here it says CLL is the most indolent of all of the leukemias, which means it's very slow growing. Now, because it grows slowly, the person may be asymptomatic. However, the problem with slow growing lymphomas or leukemias is the fact that they're hard to treat. So they can hang around for years and years and years. Okay? The mean age is around 60, so it's going to be an older patient. Okay? Now, because these B cells are neoplastic, okay, they're not going to turn into plasma cells and make antibodies. So these patients may present with pyogenic infection. Why? Because antibodies attack pyogenic bacteria. However, they will get autoimmune hemolytic anemia. Why? The normal B cells become overreactive and they turn into plasma cells and make a whole lot of antibodies and throw them out into the body, giving you the autoimmune hemolytic anemia. Okay? Now, with the SLL in particular, because it can hang around for a long period of time, it can rarely undergo malignant transformation, and the term you'll see is called Richter syndrome. Here's our peripheral smear for chronic lymphocytic leukemia. And now notice we have lymphocytes here, and note they're about the same size, only slightly larger than your red cells, telling you that they're lymphocytes and not lymphoblasts. They have scanty cytoplasm, as you can see here, okay? And here, you can see our so-called smudge cells because these cells are fragile and they smudge when you do the peripheral smear. Now let's move on and talk about hairy cell leukemia. You see here is a rare B cell neoplasm. It also is a variant of CLL. It does cause indolent disease in middle-aged Caucasian males. Classically has a so-called dry tap when you do bone marrow aspiration. What does that mean? Well, typically when you do a bone marrow biopsy, you put a little needle inside the iliac crest and put a syringe on the end of it and aspirate the marrow because marrow is actually liquidy. However, these cells are so packed in the marrow, you cannot aspirate the normal marrow elements. Ergo the term dry tap. Okay? Why is it called hairy cell leukemia? Because you have these hair-like cytoplasmic projections coming off it, giving little hairs, that kind of thing. Okay? May look like Don King or something like that, you know. The diagnostic stain is going to be our positive trap or tartrate-resistant acid phosphatase. So it's tartrate, not tartar like tartar sauce, but tartrate-resistant acid phosphatase. Okay. The patient will have an enlarged spleen, okay, secondary to the infiltration of the malignant cells. Moving on to our follicular lymphoma. This one's going to be our well-differentiated B-cell lymphoma with a follicular architecture. However, microscopically, the key is when you see the neoplasm, you're going to see follicles in the cortex and medulla. That's your effacement or disruption of the architecture you're going to look for. Considered the most common form of non-Hodgkin lymphoma in the U.S. Okay, the follicles come from B cells. So it's a B cell tumor, so things like CD10, 19, and 20 will be positive. Now, they like translocations and oncogenes, etc., with your lymphomas and leukemias. And so a translocation of 14 to 18 is important, okay? Now, you see here, chromosome 14 has the immunoglobulin heavy chain gene, and chromosome 18 has BCL2. Now, remember, BCL2 is anti-apoptotic and allows the neoplastic cells to grow. And it does that by blocking the Bax channel for P53. As far as our clinical features, typically presents with disseminated disease at advanced stage. Now, it does have a better prognosis than the diffuse lymphomas, but again, because it grows slowly, it doesn't respond to therapy. And because of that, the lymphoma can transform later on in life into a so-called diffuse B large cell lymphoma. Moving on to our diffuse large B-cell lymphoma. Now, this is a high-grade lymphoma. High-grade means that it's aggressive. So microscopically, you're going to see large cells, or you're going to see mitotic figures. Sometimes the large cells can have prominent nucleoli, okay? Now, when do you see this tumor? This tumor can be associated with HIV patients. Remember, patients who have AIDS get this non-Hodgkin's lymphoma. Well, this is the lymphoma they get. It's also associated with autoimmune diseases like Sjogren's syndrome and Hashimoto's thyroiditis. Also note its association with herpes type 8. Moving on to our small non-Hodgkin lymphoma, also called Burkitt's lymphoma. Now, this one's high grade, but it's so aggressive. Some people consider it the most aggressive of all neoplasms. We're talking about lymphomas, leukemias, sarcomas, carcinomas, etc. Okay. You typically have this so-called starry sky appearance microscopically. Okay. And what does that mean? What we're saying is the Burkitt cells are like the night portion of the sky, and you have these benign tentable macrophages, which are the stars in the sky. Here's a typical biopsy of Burkitt's lymphoma. So the light areas are going to be our macrophages, and they make up the stars in the starry sky. And then the darker cells you see here are going to be our malignant Burkitt cells. Now notice you see here, there's a mitotic figure, okay? And there are other mitotic figures that you can see. Again, showing you that this is an aggressive tumor, okay? As far as the genes associated with this neoplasm, they like a translocation of 8 to 14. On chromosome 14, we have our immunoglobulin heavy chain genes. On chromosome 8, though, is the oncogene c-MYC, so you want to know that, okay? Now, there's going to be endemic as well as sporadic forms of Burkitt's lymphoma. Classically, the endemic form is seen in Africa. It's going to be an African child with this large jaw. It's associated with Epstein-Barr virus, okay? But, you know, they're probably aware that you probably figured that out right now. So they may give you the American type, which is more non-endemic. So it's going to be an adult, probably with abdominal/pelvic lymphadenopathy. And they're going to do a biopsy showing you the starry sky, okay? And here is our picture of our child with the Burkitt's lymphoma, showing you the large jaw secondary to the proliferation of the neoplastic cells. Moving on to our mantle cell lymphoma, also called intermediate differentiated lymphocytic lymphoma. This one kind of looks like CLL in the fact that you look at the markers, CD19, 20, and 5 are positive like CLL. However, it's negative for CD23, and look for the translocation of 11 to 14, okay? You see 11 has the cyclin D gene on it, BCL1, and chromosome 14 has the immunoglobulin heavy chain gene. Now, for your marginal zone lymphoma or maltoma, which is a classic presentation, is a diverse group of BCL neoplasms that typically associated with lymphoid tissue in extranodal tissues. A classic place is in the stomach. So MALT means mucosa-associated lymphoid tissue. Like I said, you typically see in the stomach. It's going to be a patient with some abdominal discomfort, and they're going to do a biopsy of the stomach and see these aggregates of lymphoid tissue. It's important that the tumor remains localized for long periods of time. Moving on to our multiple myeloma. So now we're talking about a neoplasm of plasma cells. Typically, is the most common primary tumor arising in bone marrow of adults. Typical patient is going to be elderly male presenting with low back pain. Again, your differential will be if an elderly male does have low back pain, you've got to rule out metastatic prostate cancer. Also, an abdominal aortic aneurysm may also present that way in elderly male as well. So these patients are going to have increased serum protein with normal serum albumin. They're going to have this M spike when we do serum protein electrophoresis. Why? Because you're making one type of antibody, monoclonal gammopathy. Okay. Most common is going to be IgG. Second most common is going to be IgA. Because these proteins are also making light change, you can see these Bench-Jones proteins in the urine and in the serum of these patients. Now, if you do a bone marrow biopsy, we're going to see a whole bunch of plasma cells. Again, because it's a plasma cell dyscrasia, and they're going to be impacted in the marrow. However, in the peripheral smear, you're going to see the rouleau formation or stack of coins. Why is that? Because you're making so many immunoglobulins like IgG, the IgG will attach to the red cells, allowing the red cells to attach to each other, giving you the rouleau formation. Now, these plasma cells also will secrete osteoclastic activating factor, which will give you so-called multiple lytic or punched-out lesions in the skull and vertebra. Because of that, the patient also will have hypercalcemia, because again, osteoclasts resorb bone for calcium. Okay? They also will have fracture, of course, and it can have bone pain. Also note that because these cells are proliferating in the marrow, they can push out the normal marrow elements like leukemias, and the patient can present with pancytopenia as well. Here's our peripheral smear of multiple myeloma showing the rouleau formation or stack of coins. You can see here. Okay, they're kind of trying to stack here. Okay, and little short stacks right here. Because of the immunoglobulin production, allowing the red cells to become more sticky. In the center, we also have a large plasma cell. Now, why is it a plasma cell? Because the nucleus is eccentric, i.e. it's pushed to one side. You have an eosinophilic cytoplasm. And notice this little light area, so-called perinuclear Hoff. Okay? This actually represents the Golgi apparatus, because remember, plasma cells make a lot of protein, immunoglobulin, so therefore it needs a large Golgi to package the immunoglobulin. So therefore you see this large perinuclear Hoff next to the nucleus. Here's a picture of the vertebra showing you the lytic bone lesions, as you can see here. And of course, they'll lead to hypercalcemia and fractures. Now, what will our complications be? Increased risk of infection is the most common cause of death. Renal disease, so-called myeloma kidney or myeloma nephrosis. Now, very important, about 10% of patients are associated with primary amyloidosis. Why? Because primary amyloid is also called AL. AL stands for amyloid of light chain. So again, with primary amyloid, you also have plasma cells making Bench-Jones proteins. So be aware of that, okay? You also have increased amounts of IL-6 associated with poor prognosis because survival of myeloma cells depends on IL-6. Here is our bone marrow biopsy showing you these multiple plasma cells inside, eccentric nucleus. There could be a mitotic figure there, okay? You typically see these cells packed in the marrow, giving you the Peripheral smear picture of pancytopenia. Move on, talk about our plasmacytoma. So when we say that, now we're talking about a solitary myeloma. So this one lesion, either in the bone or in soft tissue. Okay. Within the bone, it's a precursor for multiple myeloma. Outside the bone, though, usually found within the upper respiratory tract, and typically is not a precursor lesion for myeloma. We also have a monoclonal gammopathy of undetermined significance, or MGUS, as we say for short. Here you also have M protein, typically found in about 1 to 3% of asymptomatic patients. The incidence will increase with age. Now, there is an annual risk of developing a plasma cell dyscrasia, okay, using multiple myeloma. Okay, it may also involve primary amyloidosis, B-cell lymphoma, or chronic lymphocytic leukemia. Another neoplasm that's similar to our multiple myeloma is called our lymphoplasmacytic lymphoma. Now, this one is a small lymphocytic lymphoma with plasmacytic differentiation. Okay, it's kind of like a cross between your SLL and multiple myeloma. Now, like myeloma, you're going to have an M spike, but now the M spike is going to be IgM. Remember, IgM is the largest molecule, so-called pentamer, so it's the largest antibody. Now, like SLL, the neoplastic cells can infiltrate to many organs like lymph nodes, spleen, bone marrow, the so-called RES system, right? Reticular endothelial system, okay? However, unlike multiple myeloma, there'll be no bone lesions, okay? And calcium levels typically do not increase. You can see Russell bodies, which represent packaged immunoglobulin, as well. These are called Dutcher bodies, which are intranuclear immunoglobulin, okay, that can be present. Now, because IgM is so large, okay, a term you'll see is called hyperviscosity syndrome. So the large antibody makes the blood volume very viscous. These patients present with visual as well as neurological problems, okay, as well as bleeding and cryoglobulinemia. In fact, this may cause a secondary form of Raynaud's phenomenon.